Our next speaker is Dr. Somasheila Murthy, again, another very dynamic person, a national and international figure. She's the medical director and head of the Cornea, Cataract, Refractive and Uveitis Services at Shantilal Chanvi Eye Institute, Mumbai. And she's going to talk on another very important topic, missing endotheliitis and anterior uveitis. So let's hear from you, Dr. Somasheila.
Thank you very much, Dr. Chitra. I feel like old days with the ARC meetings that we used to have. And I didn't realize that I had got addicted to them. So I'm feeling very happy to be part of this session. And also my topic may be a little bit not as interesting as Rima's wonderful talk. And that is because mine is, I'm just going to stick to the clinical presentations that we have. And also one important aspect that Dr. Vishali so astutely mentioned, that you may have a terminology, say, as she mentioned, like multifocal choroiditis, multifocal choroiditis with panuveitis, which is ascribed as an idiopathic. But once you have an etiology to it, so then you change its diagnosis to ocular tuberculosis. So this is something like that, where you might have a patient coming in with anterior uveitis, but when you have certain clinical phenotype, actually it is nothing but a viral disease, viral inflammation. And so you change its terminology, you can call it viral anterior uveitis, or you can call it viral endothelitis, based on which manifestation you see. And sometimes very subtle, but now that we've seen quite a few of these cases, we always start antiviral therapy. So coming to the subject in question, we have viral anterior uveitis as a known entity now for quite some time. In this presentation, I'm going to describe a little bit about the clinical phenotypes. I'm not describing about the common viruses causing this disease. They're listed here in this particular slide. And also I'm going to skip talking really about the debate between PCR guided therapy or clinically guided therapy. Most of the time, most of us who may not have labs or who may not have access to PCR results should go in with clinical guided therapy. And my talk is to help us make a decision on that. So let's dive straight away into the first case. This is a 35-year-old lady and who presented with decreased vision, and she was referred to us as secondary glaucoma, bad secondary glaucoma. Now, the interesting part in her case is that she's having this relentless episodes of uveitis, of inflammation, since the past 16 years. She was investigated multiple times, received therapy as topical steroids, oral steroids, etc. And because of the pattern of raised intraocular pressure with inflammation, she was diagnosed as a Poschler-Schlossman syndrome and was being treated for that. Interestingly, she also had undergone LASIK in both eyes. That is not related to anything to her etiology, but just the clinical manifestation. And she had good vision recovery after LASIK, but after the secondary glaucoma, her vision in the left eye had reduced to counting fingers. So this is the clinical presentation of the patient. What we see here in the affected eye is that there's a very steamy or edematous cornea, and we can see these discrete keratic precipitates. That's what my arrow is showing over here. Some more down here, a few up here. I hope that it is also appreciated. In addition, the patient is pseudophakic. The pupil is sort of fixed and dilated, and there is the rim of the anterior capsule, which is now opacified. The slit is trying to show an interface fluid syndrome that the patient had, not really able to capture it on slit. But on anterior segment OCT, you can see very clearly, this is the anterior surface. There's a fluid interface in between, which is separating the rest of the cornea from the LASIK flap, which was there earlier. And the entire cornea is thickened. And look at how the OCT also picks up those granulomatous keratic precipitates just hanging on the endothelium like this very well. So this is the entry-level pictures that the patient had. Intraocular pressure at this point was 42 millimeters when measured in the periphery. With the interface fluid, the pressures in the center was measuring almost normal, because you know that you'll have fallacious measurement. So in the periphery, it was 42 millimeters of mercury. She had some cells in AC, and unfortunately, an almost 0.9 glaucomatous disc cupping in that eye. So our clinical diagnosis itself was sort of a CMV keratouveitis, or you can call it CMV endothelitis and anterior uveitis with secondary glaucoma. And this was a few years earlier. And since we have access to very good lab, so we asked for, we planned to do a AC tap and send that for real-time quantitative PCR. And we also planned almost simultaneously, as soon as we take the tap, to start the patient on oral vanguard cyclovir, which is the treatment of choice for CMV endothelitis. So we started our Vangan cyclovir as well as topical steroids and of course all the AGMs, oral and topical. And meanwhile, the real-time PCR results showed that she had very high copy numbers of the virus in her from her aqueous. So we were on the right track. This is a CMV endothelitis, and just a week after starting ganciclovir, you can see how the corneal transparency has recovered. The OCT shows completely resorption of the fluid, and the intraocular pressure has decreased to 28. But because she had such a high copy load, I feel that starting the antiviral therapy worked so well for this patient. But she did need a trab with MMC because of advanced glaucoma, which was still not controlled with maximum medical therapy. And we've been following her up. I also recently saw her a year ago when I was at LVPI last year, and she's doing extremely well in terms of her cornea, intraocular pressure. She took a complete 3-month therapy of valganciclovir and did not need further therapy for either for the CMV endothelitis or for her inflammation since then. Unfortunately, vision doesn't improve beyond 20/100 because of her advanced disc damage in that eye. So this was a case of CMV endothelitis, which was sort of missed for almost 16 years that the patient has been having this disease. And why do I call it endothelitis? Especially CMV amongst the viruses, of course, HSV also, just loves the corneal endothelium, attacks that. And in the case of CMV, you can see very early distress of the corneal endothelium. Of course, this patient had the disease for so long. So it's not surprising that this was at entry level. Because of edema, you can't get the scan. And within a 4 months visit, there is the endothelial cell mosaic can be seen a little better. And this is the final visit. Even now, it's same. She has about an endo count of 1369. So the CMV virus actually adversely affects the corneal endothelial cells, causing its death. The second case is a little similar. He's a 61-year-old doctor. There's one big difference in that he's much older, and he had the history since 4 years. He was on treatment with topical steroids and AGM with high pressures recorded elsewhere. The red herring in his case, and our today's series is on red herring. So red herring in his case was he was also HLA-B27 positive and known to have that since 2014, but he barely had any ocular inflammation because of his HLA-B27, only this one. So because of HLA-B27 positivity, he was treated with methotrexate, and they were on the verge of starting biologicals for him because his inflammation would not go down. And of course, he was on anti-glaucoma medications, steroids, etc., etc. So when he presented to us, he was on 3 oral medications in all and 6 topical medications in all for the disease in his one eye. This is his pictures on presentation. So this is diffuse showing this corneal edema. You can see its haziness inferiorly. And this broad slit shows the kind of keratic precipitates pigmented, just sort of splashed in the central part of the cornea and a few inferior as well. And the picture on the side shows the left eye, which is absolutely fine. We don't think he had any episodes of inflammation in the left eye, despite being HLA-B27 positive. So this patient's vision at entry was 2016 and significant edema, as I said, especially in this area. So when we have patients with endothelial affection as well as raised pressure and recurrent uveitis, to us, the diagnosis is very clear-cut. It has to be a viral inflammation unless by any other means it is proved otherwise. And these patients need antivirals, which is a type of virus we need to either based on clinical clues like this patient, we can consider CMV again. That would be top diagnosis for me, but it can also be HSV. So we can do an AC tab to differentiate between the 2 viruses because the treatment is very different. Again, I love doing ASOCT, and you can see those keratic precipitates. They are not old ones. They're quite fresh, actually. That's why you can see them hanging like this. And the DM is thrown into folds. This is a specular microscopy for this patient. This is the right eye, the affected eye, which shows a lowered count. Luckily, he presented a little earlier on, so his cornea will not head towards decompensation, hopefully. And he recently also visited us at the new center where I'm practicing, and he's doing fairly well. Again, when we did his TAP, when he first came to us, he had very high copies of CMV DNA detected, and he improved very, very well with oral valganciclovir. One interesting fact about this patient is that even after 4 years, although his vision is good, pressure is maintained, he still uses prednisolone eye drops once a week, he says, to maintain the inflammation, to keep it under control. And he says he's tried everything else, low dose steroids, and nothing else works. So he's a doctor to boot, so he's on this therapy. This is the initial 1 month pictures. Now, the other few cases I'm going to just show you a couple of pictures just to show the clinical features. So this patient is a 33-year-old, recurrent episodes of redness for the past few years, as well as raised IOP in the left eye. See these discrete pigmented keratic precipitates just here and there. Very quiet looking eye, hardly anything. Some keratic precipitates inferiorly as well. And again, you can treat this patient with oral acyclovir to start with, because his pressures were more in the 30s actually. And but we did an AC tap. It was positive for HSV1 DNA. So we started this patient on Valgan cyclovir, and he did improve along with, of course, topical steroids. So this is some of the therapy that you can offer, either acyclovir or Val acyclovir. The dose is of course different. These are some of the other clinical manifestations. Sometimes you can have corneal edema or the keratitis component along with anterior uveitis, and sometimes you can have a conglomeration of keratic precipitates, like you can see here, like this, which are pigmented. Both these cases were HSV, as well as these two cases also were HSV. So you had this old inflammatory evidence on the lens. And here you have a central granulomatous anterior uveitis kind of picture in this patient. So these are some of the clinical pictures that I had to share. And we can, so hopefully I'm in time so that we can go on to discussion.
Yes, again, a very interesting talk, very interesting. And while all your examples were on viral etiologies, when would you actually suspect a fungal etiology for this endothelitis, Dr. Vaishali?
I think Somasheila excellent talk. And when do I suspect? She showed the beautiful signs. CMV is unilateral, high pressure. You see those coin-like opacities. Sometimes, it can be confused with Fuchs, but a very practical thing is that Fuchs does not have high IOP unless you have done a cataract surgery. Fuchs does not present with high IOP. CMV would. And I do PCRs, but that's not like my life depends on them. I go on specular microscopy, compare the counts with other, and if my cornea people are in good mood, they do confocal, try to find out owl-like inclusions, which are not very common, and I start them on ganciclovir without. I love to do PCRs, but even if I cannot do, I like to do it. I would start them on because it's just a gel treatment, Virson gel, and you can see the pressure coming down, the response, and the count on the specular increasing. So these are the parameters that I use. The herpes she hasn't touched, and I don't think we'll get much into the VZV because those are very typical, more classic. You have more of iris transillumination, which you don't have in CMV. There is more of bilaterality. But if you see the herpes group, then you do require systemic treatment in contrast to CMV. CMV sometimes, just one episode's response to Virson gel. But if there is a recurrence, then of course, as she has shown beautifully, you need to add a course of systemic antiviral. And I was very happy to see, like I also have this pilot who has bilateral CMV. And, he just uses one drop in 3 days, 4 days, steroid. It works for him. The day he stops it, it comes back. And he uses Virson gel, titrating his own frequency twice a day, and he's happy.
Yeah.
So there is low-grade thing which we do not understand, which defies the logic that how come one drop in 3 days is preventing. But if it is working for the patients, why not? It's all about patients at the end of the day. So they're commonly confused with Fuchs and many a times confused with Fuchs uveitis and many a times confused with acute anterior uveitis. That is the problem. So for comprehensive ophthalmologist, If the patient is presenting for the first time with uveitis and high IOP, it is viral uveitis unless proven otherwise. No uveitis presents with high IOP.
Right. One thing is that cornea colleagues are always in a good mood.
Ma'am, I would agree
Non-focal,
to.
I guess, is.
Ma'am, I would want to share this small anecdote. I think 10 years back when I was a fellow, Somasheila ma'am tried to show me that undulating surface on slit lamp, which she very nicely illustrated on OCT, but I couldn't appreciate them. But I said, yes, ma'am, I can see. So in case 3 of whatever series you showed, ma'am, you showed those small specks within the cornea. So do you think anterior segment OCT will be better equipped to diagnose an endothelitis? And can you differentiate it between immune stromal keratitis and endothelitis and its impact on treatment?
So the anterior segment OCT will only show us that it'll be you can measure the corneal thickness, and in somebody has a doubt whether it is old keratic precipitates versus acute inflammation. So it's beautiful to document, but you can see all of that clinically. You can see corneal edema. You may not have seen the descemet membrane folds, though you said you told me, but that you can document even better on the OCT. But what is more useful is the confocal, which Dr. Vishali and Dr. Vishali summarized it much better than cornea colleagues about the entire management. So the confocal microscopy can actually show us the distress of the endothelium, and we see that typical pattern of owl's eye appearance. We do see it, we do pick it up on confocal. We have to search, it takes a lot of time, search for that. And that can be found only it's supposed to be pathognomic for CMV endothelitis. And in the other cases, what we would see are swollen up cells or something like that in the case of herpetic herpes simplex more often. Whereas in VZV, sometimes you may not see anything much in the cornea, whereas in the anterior segment, you see a lot, like the iris changes and sometimes a dense inflammation, and you'll just see the keratic precipitates. So somehow the first two, CMV and HSV, have a higher predilection for attacking the endothelial cells first. And VZV, it also does it, but in a later part of the story, I guess, when it's untreated. And also, I should have mentioned this, that also using ganciclovir gel for the milder cases works very well. The 2 examples that I showed, the dramatic ones, were patients who were on long-term, were not, we didn't start anything, and that's why we resorted to starting oral right away. But exactly as Dr. Vishali mentioned, that in the sort of milder cases, first, second, third episode, probably we use the gel and we do get therapeutic response. So we don't always have to give oral treatment. That's what I've learned over the years.
Thank you. Thank you.
Anything else, Ashay, before we go on to our next?
One comment, one question actually of Dr. Somasheila. If there's a patient who has a lot of KPs, but there's really no inflammation, you've tried everything, but KPs are lots of KPs dusting the endothelium. Do they themselves harm the cornea? Or do you have to really address them, or can you just leave them because patient is asymptomatic, vision is 6/6? So would you treat just for the sake of the KPs?
So hi, Malika. Do you mean that the departing KPs, as in the inflammation is over and there's still some?
Yes, they don't go. The inflammation, the KPs are not going for months together, let's say.
Right.
Do you really have to chase them, or you can just observe?
So keratic precipitates, when they're clear, when the inflammation has dissolved, but the keratic precipitates take a much longer time to fade, especially the pigments in them take a much longer time to be cleared by the aqueous, and they do not harm the endothelium. I have documented these serially. I'm not published, but documenting the endothelial cell count serially. So you'll see that black appearance of the pigments. It will block out those areas, but over a period of time, it clears, and the cell mosaic and counts, everything remains good. So just KPs alone, even if with pigments, they just get cleared. It takes a long time sometimes, but they do get cleared without damaging endothelium.
Thanks. Thank you.
Can I ask?
Ashley, can I make a point? Oh, okay, Dr. Sorry, go ahead.
Sorry, Mudit. Both, as I learned from the talk, excellent talks of Somasheila. So both the viruses and the HCSV virus and the CMV can cause endothelitis. And suppose we happen to see the patient dilated and we are missing the transillumination defects and the iridoparesis, which may be accompanying some of these cases. What are the clear-cut differentiating features to help differentiate between a patient who would need valcyclovir versus a patient who would need valganciclovir?
Dr. Vishali has covered a few of these points, as in the patients who have supra high IOPs, 40s, 50s, 60s. So my tendency would be to shift towards CMV as a top diagnosis for these patients. And with CMV disease, you have less. I've never seen CMV endothelitis or CMV anterior with keratitis, like what we have in HSV. So you can have stromal keratitis or an endothelitis, focal endothelitis, or something like that. So if I have any keratitis inflammatory event in the cornea, in the stroma, then it's outright HSV. So it's not CMV. So these two features help in a nutshell. I'm sure there's some more. I cannot recall. I have a table, but I can't recall offhand. But these two would be enough. Sometimes both look fairly similar. So to be practical, if you don't have access to PCR, because valcyclovir is cheaper, I would start the patient on valcyclovir. Let's say that it's pressure in the 30s and obligingly I don't see any changes on the endothelium. So I'll think of HSV first, start the patient on a good therapeutic trial of valcyclovir or acyclovir. And if that still fails and the patient continues to behave the similar way with pressure being high, then I would conclude that this is probably CMV and then add treatment for that. So that is one more approach.
Yeah, I agree. CMV is unilateral. You generally see low-grade inflammation. IOP is high. There are pigmented capes. And, if you see the coin-like opacities, that's very, very typical for CMV. But when you look at the herpes, they tend to be bilateral. You will have the transillumination defect and the stromal thickness. Like Somasheila said, the moment I see thickening in the stroma, a disciform lesion, capes concentrated around the corneal edema, few folds going here and there, even if there is no obvious keratitis, that is the thing for herpes for me.
Yes.
Very well said.
Very well
You don't
summarized.
need